Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in our conversation with Cancer Expert series, I have with me Dr. Hans Lee, a rising star, associate professor, and director of the Multiple Myeloma Clinical Research Program at one of the top cancer centers in the world, MD Anderson. And we're going to be talking about Celmods, a new class of drugs that we expect to be on the market in the future for myeloma. So welcome, Hans.
Thanks so much. Thanks, Ravi, for having me on the program.
So Hans, I guess to start off, can you tell our audience about what cell mods are and how do they mechanistically seem to work?
Yeah, that's a great question. So Celmods are basically molecular glues, and they're in the same class of drugs as previous iterations of myeloma drugs that we're familiar with, lenalidomide, pomalidomide, and thalidomide. And essentially what they do is that they bring together this complex on the left part of the slide, this E3 ubiquitin ligase, and basically bind to this molecule called cereblon. And basically in doing so, it recruits proteins that might be important in the growth of cancer cells, in this case, Ikaros and Aiolos in multiple myeloma, and basically allows these proteins to be tagged by this other protein called ubiquitin, and basically leads to degradation of these key proteins in myeloma growth, and hopefully leads to myeloma cell killing as a result. And one of the interesting things about Celmods that potentially differentiate them from their previous iterations, lenalidomide, pomalidomide, and thalidomide, is that they're more potent. And so essentially, they bind to cereblon more tightly. They can also induce greater potency in substrate degradation of Ikaros and Aiolos. And so what we're seeing is that they have activity in patients and in laboratory models that are resistant to lenalidomide and pomalidomide, for instance.
So obviously, Celmods are cereblon modifying drugs. You're saying that that's where the target. So I guess in clinical development, we've seen two that have had data presented, and we'll go through this in the next few slides. So can you tell us about iberdomide? What do we know about this drug? And then we can talk about the other one.
Yeah, so iberdomide was initially known as this compound called CC220220, and it was initially studied in relapsed refractory multiple myeloma patients that were heavily pretreated, had many lines of prior therapy. And many patients actually had been exposed to lenalidomide and pomalidomide, actually refractory to these agents. And initially, there was what we call a dose escalation phase where they try to find the right dose of the drug. And ultimately, the dose that was considered to be the appropriate for what we call the dose expansion or phase 2 was 1.6 milligrams by mouth daily for 21 out of 20 days. So very similar to the lenalidomide and pomalidomide dosing schedule. And what they found was in this study was that the overall response rates in patients who received iberdomide at the recommended phase 2 dose was about 26% or so. And so definitely single agent activity was seen with this drug. And I think really, really importantly is that activity was seen in patients that were refractory to lenalidomide and pomalidomide.
And not only that, it seems like it may be active against drugs that we are now using even in later lines of therapy, are BCMA-based treatments, of which we have bispecifics and CAR-T. So what can you tell us about the data in this even more refractory population?
Yeah, that's a great point you make, Ravi. And I think this is the next frontier in multiple myeloma, is that what do we do for patients who are again refractory not only to IMiDs, proteasome inhibitors, CD30 monoclonal antibodies, but now BCMA. And we're seeing this a lot more in the clinic today in 2024. And so what was really, really encouraging is that about a fourth of patients in cohort I of this particular study did respond to iberdomide and dexamethasone as well. So again, it's very encouraging to see that single agent activity, but ultimately, we'll see more use in combinations, and I think that will be very, very encouraging in the future.
So, in terms of the effectiveness, it seems like we already have moved from single agent and dual activity with dexamethasone to exploring combinations. So, what can you tell us about some of these data sets?
Yeah, in myeloma, I think we know historically that there's a lot of strength in using drugs in combination, and there's synergy and additive effects when adding these drugs together. And so we're seeing that with iberdomide too. And first we're seeing a very nice response rates by iberdomide in combination with daratumumab and dexamethasone, and also iberdomide in combination with bortezomib dexamethasone here on this slide. And not only do we see the effectiveness and the efficacy based on overall response rate, but also safety and tolerability as well. So that's obviously a key component when we start adding drugs together. And so, we combine drugs when using lenalidomide, pomalidomide. Similarly, I think that's going to be the major strength of this class of drugs. In this case, iberdomide, is that we can combine it with other agents active in multiple myeloma.
So I guess the other compound in development is mezigdomide, and I know there was a New England Journal article not too long ago on this, Paul Richardson being the first author. So can you tell us a little bit about this trial?
Yeah, so mezigdomide, otherwise previously known as CC92480. So this is another Celmod, and so structurally, it's going to be a little bit more potent, at least preclinically, than iberdomide, the previous Celmod that we talked about. And in this particular study, again, it went through an initial dose escalation where they tried many different doses, many actually different dosing schedules. So sometimes, 14 out of 28 days, or different again schedules of giving the drug. And in this particular study, patients were very, very heavily pretreated. So all the patients actually in the dose expansion actually were triple class refractory. So they were refractory to all the key myeloma drugs, IMiDs, protease inhibitors, and anti-CD38 monoclonal antibodies. And also in this particular study, a lot of patients actually had something called extramedullary disease. So basically tumors outside of the bone marrow, and about 40% of patients actually had what we call extramedullary plasmacytomas in this particular study.
And so what do we know about the activity of this drug?
So the dose that was settled upon for mezigdomide was 1.0 milligrams daily for 21 and 28 days. And so there was a dose expansion cohort that looked at this particular dose. And what was very encouraging was that there was quite a high response rate for a single agent oral targeted therapy. 41% actually of patients responded in this really heavily pretreated patient population. Again, all patients were triple class refractory. And I think there's a couple also key subsets that are looked at as well in terms of response. So first, I mentioned that a lot of patients had extramedullary plasmacytomas, about 40%, and about 30% of patients did respond with extramedullary disease, which is really a hard subset of patients to treat in multiple myeloma. And then we talked earlier about the anti-BCMA refractory or exposed patients. And again, 50% of patients responded in that particular subset as well. So this potentially is a very promising therapy, either pre or post BCMA.
And how durable are these responses?
So in this particular study, when they combined with mezigdomide and dexamethasone, duration of response was about 7.5 months or so. And the median we call progression-free survival was just north of 4 months. So this is really on par with a lot of these drugs that we saw approved for multiple myeloma, like daratumumab, pomalidomide, carfilzomib. And so I think what we're seeing is that in even more heavily pretreated patient population, patients that are now refractory to all those previous drugs, we're seeing that similar activity.
And how is this drug tolerated?
So the main side effect that we've seen with mezigdomide is myelosuppression. So basically decrease in the blood cell counts, neutropenia. So you can see that the rate of grade 4 or higher neutropenia was actually a little over 50%. And consequently, when the neutrophils are low, that can increase the risk for infection as well. So that's one thing that was also seen uh, in about a third of patients in the dose expansion cohort.
So, can you put these two drugs side by side and say what the pros and cons of these two drugs are?
Yeah, that's a great point. So we have two drugs, two Celmods, CC220 and C2940, iberdomide and mezigdomide, and they have a lot of similarities. They have a very similar mechanism of action. I would say that preclinically and clinically, there does seem to be increased potency with mezigdomide, so the latter drug that I discussed. And so that's where we're seeing a little higher response rates in the more heavily pretreated patient populations. We're seeing the response rates in extramedullary disease. But on the flip side, we're seeing a little bit more toxicities, myelosuppression, neutropenia. So, perhaps mezigdomide might be more useful. And again, patients that really need that response that are more heavily pretreated. And also, I did mention that these drugs also have important immunomodulatory activity. So they enhance T cell and NK function. So we're also thinking that these drugs might combine well with drugs like bispecific T cell antibodies, like anutumab, for instance. There's a trial looking at that as well. So iberdomide, as you know, had a little lower response rate, 26% in the study that we just discussed, but it's a little bit better tolerated. And so you're seeing a little less myelosuppression. So, perhaps it can be used perhaps in combination in earlier relapsed refractory multiple myeloma, and there are studies looking at that, and also maintenance as well. So in maintenance, we're really concerned about myelosuppression. You don't want to decrease the blood cell counts too much after autologous stem cell transplant, and there are studies looking at iberdomide in that setting.
So, talking about the studies that you talked about, obviously the drugs have yet to come to market. And could you just briefly tell us about how these are currently in study to be able to be available to patients in the future?
Yeah, it's a great question, and there's really several important pivotal phase 3 studies that are ongoing that hopefully will lead to the regulatory approval of these agents. So the first study is iberdomide, daratumumab dexamethasone versus standard of care daratumumab bortezomib dexamethasone. So one thing that's nice about the study is a 3 versus 3 study. So not 3 versus 2, but 3 versus 3. And basically looking at this in earlier relapse refractory multiple patients, with one line of prior therapy. And so this is known as the Excalibur study. And again, very important study. It's ongoing and occurring currently. As I mentioned earlier, iberdomide is also being looked at the maintenance setting. So we know that the current standard of care after autologous stem cell transplant is to do maintenance lenalidomide or Revlimid. And so there's actually an ongoing study now that will randomize patients to either lenalidomide, which is standard of care, versus iberdomide after high dose chemotherapy and autologous stem cell rescue. And the third study is a study with mezigdomide. So this is a pivotal phase 3 study looking at mezigdomide, bortezomib dexamethasone, that's the experimental arm, versus the standard of care pomalidomide, bortezomib dexamethasone, or PVD, in earlier relapsed refractory multiple myeloma. So again, a nice design because it's 3 versus 3. So that's hopefully we'll see some good results with that, and maybe lead to the regulatory approval of mezigdomide in that setting.
So obviously in myeloma, we've been very fortunate that we've had unending pipeline seemingly of new drugs and new options over the last 20 years. And it seems like we still have a robust pipeline in development. With all these new drugs, bispecifics, CAR Ts, and still others to come, I'm sure. Where do you see in 5 years from now, when these drugs are hopefully on the market, that this is going to be maximally utilized? It seems like you mentioned that these have certain properties that make them actually pretty amenable to actually enhance the effect of our immunotherapies, perhaps even.
Yeah, I think that so much focus has been on the novel immunotherapies, which obviously are very exciting, the CAR T therapies, the bispecific T-cell antibodies, but we need drugs of all classes, many classes for our patients. And so I think, don't forget about the oral targeted therapies as well. They're oral, so they're easier for patients to take in that setting. They'll obviously lead to greater access to these agents, hopefully across both regionally U.S. but across the globe as well. And so, we're seeing that these drugs are definitely active in patients, again, resistant to standard care, lenalidomide and pomalidomide. They can be used in combination, not only combination with other oral or IV drugs, but also with novel immunotherapies as well. And so I think there's a lot of promise with these drugs moving forward. I think they're going to form probably a new backbone of many regimens in the next 5 to 10 years as we look to seek greater, better outcomes in patients, both in terms of efficacy, but also quality of life as well.
Well, I want to thank you for taking the time to go over this data and tell us about these exciting new drugs. And as these move into further trials and developments, and to discuss even other developments in myeloma, I hope I can turn to you and to educate us more about developments to come in the future.
Thank you so much. It was really a pleasure to be on the program, Ravi. Thank you so much.
Thank you.